So what exactly is calcinosis? Well, it is calcium deposits under the skin. And what are these calcinotic lesions made out of? They're made of calcium hydroxyapatite crystals, and you can see the chemical structure here. And basically it shows that there's calcium, there's hydroxides, and there are phosphates in the chemical structure of calcinosis. So there are various connective tissue diseases that are associated with calcinosis, and scleroderma or systemic sclerosis is one of them that is frequently affected by calcinosis. Dermatomyositis is the other disease where a large portion of patients suffer from calcinosis, particularly those with the juvenile form. So up to 40% of patients with juvenile dermatomyositis will suffer from calcinosis, and about 20% of adult patients. And this can be associated with various autoantibody types, just like it can in scleroderma patients. In lupus, calcinosis tends to be more rare, and in mixed connective tissue disease, if patients have features of scleroderma or dermatomyositis, they're also at an increased risk for developing calcinosis. So calcinosis is associated with the CREST phenomenon, calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasias, which we used to use as a term for limited cutaneous systemic sclerosis. So people used to think that calcinosis was more common in limited patients, but it definitely can affect patients with diffuse skin involvement as well. And calcinosis typically occurs in areas of repetitive trauma, so we think that trauma does have some role in leading to calcinosis. The most common locations that are affected with calcinosis and scleroderma are the hands, first and foremost, followed by the elbows and the knees, arms, legs, and less frequently the trunk, and even less frequently the face, luckily for patients. Calcinosis is typically nodular in patients with scleroderma, but it can be plaque-like, particularly in patients with dermatomyositis. So here are some pictures of what calcinosis can look like affecting the hands in scleroderma. So most patients usually are lucky enough to just have 1 or 2 lesions affecting the fingertips. You can see this patient has quite bulky nodular lesions of calcinosis affecting multiple digits and even the palm of the hand. So this just shows the various severity of calcinosis affecting the hand. So it definitely can be very mild, and you probably can't even see too well with the lights on, but there's a very small lesion affecting the thumb of the hand here, showing one lesion of calcinosis that is very mild in terms of its density. Once you have a couple of lesions, this patient has lesions affecting the thumb as well as the fingertips here on the 4th finger, as well as even along the 4th finger and 5th digit. So there are multiple lesions here. There's also a little lesion here on the tip of the 5th digit here. Multiple lesions, higher density, we consider that kind of moderate disease in terms of calcinosis. And then if you look at the bottom x-rays, certainly these patients have more severe calcinosis affecting multiple digits with multiple lesions and even affecting the wrist down in this patient. So as I mentioned, calcinosis is pretty common in scleroderma patients. We did a large survey looking at more than 7,000 scleroderma patients who are seen internationally and found that the frequency is about 22% in scleroderma patients overall to be affected with calcinosis. It is a little bit more common in those with limited skin involvement, so about 25% of patients with limited skin involvement will have calcinosis compared to 17% in diffuse scleroderma. Interestingly, 28% of patients with systemic sclerosis sine scleroderma can also have calcinosis, and it might be that those are the patients that we used to call CREST, so they have basically no skin tightening, but they have internal organ involvement related to scleroderma. And this picture here is just a reminder of the difference between diffuse and limited skin involvement. So patients with diffuse cutaneous systemic sclerosis can have skin tightening essentially involving the entire body, compared to limited cutaneous systemic sclerosis where they get facial involvement and maybe some hand, forearm, lower leg, and foot involvement. And then in those with systemic sclerosis sine scleroderma, basically the whole picture would be white. They have no skin tightening per se, but they could have some puffy fingers and then certainly have internal organ involvement related to systemic sclerosis. So even those patients with no skin tightening at all can be at risk for calcinosis. The other thing that we found in this large study was that patients with calcinosis have a longer disease duration. So we know that this is a late complication in scleroderma patients, and that is probably because calcinosis is related to a lot of blood vessel damage. That's what we think. So in terms of clinical features associated with calcinosis and scleroderma, yes, it's probably more common in those with limited skin involvement or even in the sine sclerosis group who have no cutaneous involvement. Those with longer disease duration. And a couple of autoantibodies are associated with an increased risk for calcinosis and scleroderma. And those are the anti-centromere antibody, which is pretty common. About a quarter of patients can have the anti-centromere antibody. And also the anti-PMSCL or the anti-PM1 antibody. There are two different names for this antibody. This antibody stands for anti-polymyositis/scleroderma. And so these patients are often at increased risk for developing inflammatory muscle disease as well as calcinosis. It's only present in about 5% of scleroderma patients, but definitely if you have this antibody, you should be looking out for muscle inflammation as well as calcinosis in the future. Male gender has been associated with an increased risk for calcinosis. The reason for that is unclear, but typically men are known to have more severe disease, and perhaps they have more inflammation that leads to more damage as the disease progresses. Finally, history of digital ulcers. Severe Raynaud's, digital ulcers, and digital ischemia have all been associated with having an increased risk for calcinosis. So maybe there's some blood vessel issue that's leading to calcinosis as well as death or necrosis of the digits. Dystrophic calcification is a term that is used to describe the calcinosis that affects patients with connective tissue diseases. It is defined as deposition of calcified material in damaged tissues, but in the presence of normal calcium and phosphorus levels in the blood. So they're actually calcifying and depositing in the skin and other tissues, but isn't associated with high levels in the blood. So this is a picture of a digital artery from a patient with scleroderma, and I always like to show this picture because it epitomizes the blood vessel damage that occurs in scleroderma patients. So you can see surrounding the blood vessel is the blue staining, and that's all related to scar tissue. This is the smooth muscle layer, and then this is the endothelial cell layer or inner layer of the blood vessel. It really should only be one cell thick, but you can see here it's replaced almost entirely with scar, and this limits the amount of blood that can flow through to the digits. So because of this blood vessel scarring or blood vessel fibrosis, you get tissue ischemia or loss of oxygen and blood flow to the distal tissues. You get tissue damage, and we think that this leads to calcium deposition. There are certain molecules that are elevated in the blood and in actually the calcium deposits themselves. These molecules are called calcium-binding amino acids and gamma-carboxyglutamic acid, or CBAA and GCGA. These are increased both in the bloodstream of scleroderma patients with calcinosis as well as the calcinosis lesions themselves. There are also inflammatory molecules that are increased in the milk of the calcium deposits. So you know that discharge that you get when you squeeze out the liquid from the calcium deposits? They actually have inflammatory markers. These include interleukin-1, interleukin-1 beta, interleukin-6, and tumor necrosis factor alpha. All of these inflammatory molecules are elevated also in rheumatoid arthritis, in joints from rheumatoid arthritis patients as well as their bloodstream. And we actually have drugs that target these inflammatory markers. Acrosteolysis, this is a big word describing the bony resorption of the end of the digit that happens in scleroderma patients related to poor blood flow to the digits. So it's associated with having severe digital ulcers and ischemia, and also is associated with the development of severe calcinosis. So again, we think that this blood vessel problem is leading to digital ulcers, digital ischemia, acrosteolysis, and calcinosis, that all of these are related to the problem with the blood vessels in the digits of scleroderma patients. So just to show you what it looks like clinically, you can see that this index finger is shortened because of the bony resorption, and it correlates with this finding on X-ray, where you lose kind of the tip of the bone there. So calcinosis is clinically affected or associated with a lot of complications, pain being the predominant problem. So patients complain that the calcinosis over pressure areas is very painful, especially over the elbows, constantly bumping the elbows with calcinotic lesions. Also, the inflammation that surrounds the calcinosis causes a lot of discomfort to patients. So as you saw, the calcinosis lesions can affect the digits very frequently and other areas of the hand, so you get impaired hand function. They can sometimes come to the surface and ulcerate and become infected. And sometimes calcinotic lesions are so large that they actually put pressure over a nerve, such as in the wrist or elsewhere, and can lead to neurologic symptoms. So how do we assess for calcinosis? Well, you certainly can look on physical exam and try and feel for that hard little nodule right under the skin. Sometimes it's hard to tell whether that's calcium, whether that's, just scar tissue. It's sometimes hard to clinically detect really small lesions of calcinosis. So one way we assess for the presence of calcinosis is very simple, and that's just by hand x-rays. A very simple procedure that is very cheap, safe, and we can assess for the degree of calcinosis. If you have calcinosis affecting the trunk, particularly those patients with dermatomyositis can get them on the trunk, a CT might be more appropriate, and really to look at those plaque-like lesions that can affect the trunk in dermatomyositis patients. Ultrasound has also been used and has been found to correlate well with x-rays in determining the presence of calcinosis. It's still considered experimental, but does seem to be very good at assessing for the presence of calcinosis. Obviously, in ultrasound, you're not having any radiation, so this may be a good way to assess the burden of calcinosis in the future. So briefly, I just wanted to go over a new radiographic scoring system that we have just developed for monitoring and assessing the severity of calcinosis in the hands of scleroderma patients. I'm pretty excited about this study just because really there are no outcome measures that are available for looking at agents to use for the treatment of calcinosis in clinical trials. So that's the first step. In order to get a drug approved for a certain indication, you have to have what we call validated outcome measures to use in clinical trials. These measures have to correlate with disease severity and have to be reproducible by different raters. So, if one rater at Stanford is looking at a certain outcome measure, it agrees with another rater at UCLA. So basically, this is called interrater reliability. You also want to make sure that the outcome measure is reproducible. So if I measure it today and the lesion doesn't change in 2 weeks, when I measure it in 2 weeks, the measure should be the same. And that's called intra-rater reliability. So I just want to introduce these background terms and let you know that this study is the development of a new radiographic scoring system for calcinosis. So hopefully we'll be able to actually start doing some clinical trials for drugs for this indication. So our objective was to develop and validate a novel radiographic scoring system for calcinosis affecting the hands of patients with scleroderma for potential use in clinical trials. I showed you x-rays of the hands, and there was a prior scoring system that was pretty simple, just grading x-rays as mild, moderate, or severe. And again, we went through these x-rays a little bit earlier in terms of the severity of calcinosis. So mild is if there's a single site of low density. Moderate is if there's medium density at one or more sites, or a single site of high density, meaning it's brighter on the x-ray. And severe is having more or one site of high or mixed density, so lots of lesions that are very bright. This is the new radiographic scoring system that we're trying to develop. The simple one really wasn't able to tell us the degree of severity of calcinosis. So if you go from mild to moderate, you really need a drug that is a gangbuster. And you aren't really able to look at each individual lesion and see if it's improving in size. So, a large lesion might improve, whereas the multiple small ones don't improve, and you wouldn't be able to capture that with the simple scoring system. So we developed a more complex scoring system where we broke each hand down into 22 different anatomic regions, and we had investigators score each of these 22 regions if they saw calcium in them. So looking at the percent of the area that was covered, the density, as I mentioned, how bright it is on the x-ray on a scale of 1 to 3, and then there was a weight for how much percentage area each was out of the 22 anatomic sites. Using that system, then we had 12 raters look at 12 different radiographs of scleroderma patients with different severity in terms of their calcinosis. And looking at the simple scoring system, we looked at the agreement between raters and the agreement within raters. So raters were supposed to repeat their assessments a few days later and see how well they agreed with themselves. And basically a kappa score or an ICC correlation coefficient, intra-class correlation coefficient, these are measurements of the inter and intra-rater reliability. And the closer to 1, the better. So as you can see here, the simple scoring system, the inter-rater reliability is pretty poor, 0.39. And the intra-rater is a little bit better at 0.67, but that's still considered mild to moderate and how good of an agreement there is. When we looked at the complex scoring system that we just developed, the inter-rater agreement between raters was 0.89, so quite high. And the intra-rater agreement within yourself, when you repeat the assessment, was even better at 0.93. So this really validated the fact that the complex scoring system was a better and more reliable scoring system than the simple scoring system that was previously published. So these results are going to be published in Arthritis Care and Research very soon. And like I said, the reason it's exciting is because now we can implement this for clinical trials for new agents to use in calcinosis. So now I'm going to talk about the therapies we have available for calcinosis. And we do have a lot that have been tried, but never tested in clinical trials, so we really don't know the true efficacy. So first of all, therapies for calcinosis can either be for prevention of new lesions, treatment to reduce the size and number of current lesions, or treatment of complications such as infection. So in terms of prevention of calcinosis, we tell all of our patients really try and avoid trauma. Also, try and effectively treat your ray nodes and make sure that you have good blood flow to your extremities. That can be by keeping yourself warm, not smoking, avoiding stressful situations that might bring on your Raynaud's, and using medications that help your Raynaud's and your blood flow and treatment of digital ulcers. For treatment of infections, calcinosis can certainly break through the skin and ulcerate. We try to encourage patients not to pick at their lesions and ulcerate them themselves. I know it's sometimes very hard to not do that. But if you certainly notice any spreading redness around the ulceration or any green, yellow, thick discharge, that means that it's infected and should be treated with antibiotics. So there are other treatments for calcinosis to try and reduce the number and size of lesions. And there are oral medications, none of which are FDA approved. These all take months to years to see an effect, so you have to be very patient. And they can be used in combination, though, again, we don't have any clinical trials showing that combination is better than monotherapy or single therapy. You can get corticosteroid injections, and I'll talk a little bit about some data supporting that. There are now some laser therapies that people have tried. Extracorporeal shockwave lithotripsy has been tried. That's what we used to treat kidney stones. And surgical removal, tried and true method of treatment for calcinosis. So I'm going to review the data supporting this whole list of medications used for calcinosis. And I should say data with a caveat. These are all just case reports, case series published in the literature saying that calcinosis improved with these medications. They're very small numbers of patients. None of them have been proven in clinical trials. So, if your doctor tells you this medication works for sure, I think that has to be taken with a grain of salt. We really don't have the data to support any of these agents. But calcium channel blockers, we use them a lot. We use them to treat Raynaud's and digital ulcers. It's approved for the treatment of high blood pressure or hypertension. The doses for diltiazem to use for calcinosis are typically from 240 to 480 milligrams a day. And it works by increasing blood flow because they open up the blood vessels. So again, we think that calcinosis is related to decreased blood flow to the fingers, just like Raynaud's and digital ulcers. The other way that calcium channel blockers can affect calcinosis itself is that they lower the ability for calcium deposits to form by increasing calcium flow into the cells. So rather than having the calcium deposit in the tissues, they actually go inside the cells. So of course, calcium channel blockers are associated with some side effects. They lower the blood pressure as they're supposed to do for hypertensive patients, but a lot of patients with scleroderma have low blood pressure to begin with, so you may get some lightheadedness or dizziness associated with treatment with calcium channel blockers. They also notoriously cause swelling of the legs, so that could be a side effect that may limit its use. And then headaches are also pretty common associated with these drugs. Colchicine is a drug that is approved for the treatment of gout and pseudogout. Pseudogout are calcium pyrophosphate crystals that deposit in the joints, usually in patients with osteoarthritis, but with other metabolic problems as well. Colchicine is considered an anti-inflammatory drug. And so we think it works in calcinosis by decreasing the inflammation around the calcinosis and around the ulcerations. But really there hasn't been proof that it changes the burden of calcification itself or decreases the size of these lesions. So treatment doses are 0.6 to 1.8 milligrams a day, and potential side effects, mostly GI, diarrhea, abdominal pain is very common, and rarely can affect the nerves or cause muscle damage. Probenecid is actually another drug used for the treatment of gout. The thought is, okay, treatment of crystal disease, maybe this can affect calcinosis as well. Probenecid is dosed at 250 to 2,000 milligrams a day. And it's thought to work in calcinosis by increasing phosphate excretion through the urine. So this decreases the phosphate in the blood and potentially the phosphate that's available to calcify or crystallize with the calcium in the blood and form calcium deposits under the skin. Probenecid also has potential side effects, including rash, diarrhea, and the development of kidney stones. Minocycline is an antibiotic. It's dosed from 50 to 200 milligrams a day. It's frequently used to treat acne rosacea. It actually has been used even to treat rheumatoid arthritis patients with joint swelling. It's thought to bind to calcium and decrease inflammation. So again, might be useful for those calcinotic lesions that are associated with some inflammation surrounding them. So minocycline can decrease the frequency of ulceration and inflammation associated with calcinosis, and it may actually decrease the size of the calcinosis lesions themselves. We actually do use minocycline or try minocycline for patients with calcinosis and scleroderma and dermatomyositis. Again, I haven't seen a huge benefit, but I would say the times where there's a lot of inflammation surrounding the lesions is the times I would most frequently want to try the minocycline. Of course, there are potential side effects. Dizziness is very common, skin rash can occur, and usually when you're on the antibiotic for a longer period of time, skin pigmentation can occur. Bisphosphonates are drugs that are approved for the treatment of osteoporosis. So alendronate, 10 milligrams a day, or etidronate, 20 milligrams per kilogram per day, are the approved doses and the doses that have been tried for calcinosis. So these are thought to work by decreasing the calcification process by decreasing calcium turnover from the bone. So keeping the calcium in the bone rather than in the bloodstream in order to calcify with phosphates and hydroxides. Bisphosphonates also have some anti-inflammatory properties, so it could also be decreasing the inflammation surrounding the calcinosis. And potential side effects can lead to stomach irritation or ulceration, and that's why you're instructed to sit upright for 30 minutes, empty stomach, trying not to worsen your reflux by taking these medications. Bisphosphonates are also associated with bone pain and can also lead to headaches. Warfarin or Coumadin is another medication that has been used for the treatment of calcinosis. It's approved for the treatment and prevention of blood clots, used in patients with antiphospholipid syndrome or patients who have deep venous thrombosis not even associated with antiphospholipids. So the dose that has been used for calcinosis is 1 milligram a day. And it's thought to work by decreasing those molecules that are found in the calcinotic lesions, the GCGA, and decreasing it in the blood so that potentially it won't deposit and make these calcifications. It also is thought to work by increasing calcium binding in the bone through its effects on vitamin K. Warfarin at this dose is actually pretty safe, but there is still a low risk for bleeding, and very rarely skin necrosis happens with warfarin. Aluminum hydroxide is a treatment that's approved for hyperphosphatemia, and it's also used as an antacid, so it may help your indigestion or your heartburn as well as your calcinosis. The dose is 1.8 to 2.4 grams per day, and it's thought to work by binding phosphorus and thus decreasing phosphorus absorption in the gut, so it can't form calcifications with calcium. There are case reports of aluminum hydroxide softening and decreasing the size of calcifications, but no reports of complete resolution of calcinosis. There are some potential side effects with aluminum hydroxide, mostly gastrointestinal, so nausea, constipation, stomach cramps can occur. Also, you can't use aluminum hydroxide if you have kidney failure. So the aluminum will actually accumulate and cause osteomalacia, which is softening of the bones, or it could also lead to osteoporosis. So if you do have kidney failure, you cannot take aluminum hydroxide. Sodium thiosulfate is a newer drug that is available from 10 to 25% in an IV formulation, as well as topical and intradermal. So you can just put it under the skin, actually. And it's an approved treatment IV for cyanide poisoning, of all things. But more recently, it has been used in the treatment of a disease entity called calciphylaxis, where you get calcification in blood vessels that causes skin necrosis or skin death in patients with kidney failure. So this is now an approved treatment for calciphylaxis, and it's thought to work by increasing calcium solubility. So, you would think that that would help calcinosis and scleroderma patients. There are case reports of success, not just with the IV formulation, but even with the topical formulation and the intradermal formulation of sodium thiosulfate. So this may be an agent that's going to go further for development to treat calcinosis and scleroderma. There are side effects, particularly related to the IV formulation. The topical and intradermal formulations are more local treatments, so less side effects. But with the IV form, you can get lowering of the blood pressure, nausea, vomiting, disorientation, and headache. So a lot of associated side effects, but it may be that the IV formulation is necessary for those larger areas of calcinosis. Intravenous immunoglobulins, or IVIG, this is an infusion that's given to patients for the treatment of autoimmune blood, neurologic, and muscle disorders, as well as given to patients who have primary immunodeficiency. So it's approved for multiple treatments of different autoimmune diseases. And they're infusions that are given over 2 to 5 days every month. So monthly infusions for a few days each month. And in calcinosis, we think it may work by actually controlling the underlying disease activity, particularly in patients with dermatomyositis. We think that calcinosis is related to disease activity and damage that the tissues sustain after having a lot of active skin disease. So IVIG may work by controlling that inflammation and, again, the underlying disease activity. There are a lot of potential side effects for IVIG, and I think in most cases we're giving the IVIG only if they have evidence of other disease activity, but not for the calcinosis alone. So allergic and infusion reactions, headache, aseptic meningitis is a problem that you can get related to IVIG, and there's an increased risk for clot formation as well. Rituximab is an immunomodulatory therapy that is approved for the treatment of blood cancers and also approved for the treatment of rheumatoid arthritis. It's usually an infusion that's given every week for 4 weeks. It can also be given 2 times, 2 weeks apart. And it is thought to work basically by decreasing inflammation. So this does affect your immune system quite significantly and immunosuppresses patients. So definitely these patients are at higher risk for infection. Thus far, there's just been one case report for the successful use of calcinosis in a scleroderma patient. So I'm not sure how much more data will be published regarding this, but there was just one report in the literature thus far. So regarding corticosteroid injections, again, these can be helpful, particularly in those calcinotic lesions where there's a lot of inflammation surrounding them. Of course, there is a risk for an infection, but the risks are fairly low. And it doesn't actually prevent or decrease the calcinosis lesions themselves, so it really just helps with the pain and inflammation. In terms of laser therapies, these are bloodless procedures and can be helpful for the treatment of small superficial calcinosis lesions. So there are a couple of different lasers that have been used, a carbon dioxide laser and an erbium-doped yttrium aluminum garnet laser. I have really not seen one of these myself, but there are reports that you can have decrease in size of the calcinotic lesions. Excuse me, even after just one treatment. Excuse me. So it does take some time to heal, probably about 6 weeks healing time after one treatment. And there is a risk for infection post-procedure, and there's also potential for recurrence. So I had mentioned that extracorporeal shockwave lithotripsy has also been used for calcinosis. This is an approved treatment for kidney stones, and they're basically acoustic shock waves that are used to break apart calcifications. So it's been tested in superficial calcinosis lesions and has been shown to decrease associated pain, but you may have difficulty accessing some of these lesions depending on if patients have contractures. So there is some difficulty with positioning. The sessions have to be given every 3 weeks for at least 6 months to see any change. And finally, surgical removal. So surgical removal is reserved for localized lesions or to debulk really large lesions. So when a patient is pretty symptomatic from calcinosis and there's a fairly large lesion or a lesion that's quite accessible to surgery, we will refer the patients to get these removed. It's successful in the majority of cases, and almost all patients will have some response in decreasing the size of the lesion. About 75% will actually have complete resolution of the calcinosis lesion that is removed. And there's usually associated improvement in pain and function. The problem is recurrence can happen in about a quarter of cases. There's also potential risks, including slow wound healing, infection, and potentially, depending on where the lesion is, a decreased range of motion post-surgically. So this table describes the Mayo Clinic experience in 78 patients who had autoimmune connective tissue disease-associated calcinosis. So of the 78 patients, 30 of them did not have any treatment at all, and none of those patients had a response. 19 patients had only medical therapies used, 11 patients had surgical therapies alone, and then 17 patients had medical and surgical therapies for their calcinosis. So of the 19 patients who had medical therapies alone, only one of them had a complete response or remission of their calcinosis. 6 of them did have a partial response, 5 had no response, and then 7, their follow-up was unknown. For the surgical cases, 8 out of the 11 had a complete response and 3 had a partial response. So the surgical outcomes looked pretty good. When patients were treated with both medical and surgical treatments, 14 of them had a complete response, 2 of them had a partial response, and only 1 had no response. So again, surgical or medical and surgical treatments together seem to lead to pretty good response rates in terms of the calcinosis. So, as I mentioned, now we're at a state where we can start developing clinical trials for agents for the treatment of calcinosis using new outcome measures that have been developed. And so some of the agents that we're interested in looking at are vasodilatory agents, agents that open up the blood vessels. As I showed you, there's an association with digital ischemia, digital ulcers, acroosteolysis, and the development of calcinosis. So looking at agents that can open up the blood vessels, drugs we have currently available for the treatment of pulmonary arterial hypertension and also frequently used for severe Raynaud's or digital ulcers. These are agents like sildenafil or tadalafil, which are called phosphodiesterase 5 inhibitors, or even more powerful prostacyclins such as epoprostenol or treprostinil. There is also, as I mentioned, a lot of data that anti-inflammatory agents may be very effective for the treatment of calcinosis. So tumor necrosis alpha inhibitors and other agents such as cyclosporin or tacrolimus may be looked at in the future in terms of affecting the inflammation surrounding calcinosis. So in summary, calcinosis is a common problem affecting about 22% of patients with scleroderma. Most commonly, it affects the hands and probably related in part to trauma as well as poor blood flow to the digits. Also, calcinosis is associated with a high degree of inflammation, and these lesions can ulcerate and get infected. A combination of medical and surgical therapy seems to lead to the best outcomes in terms of treatment of calcinosis. And we now are embarking on new clinical trials with new outcome measures to test the efficacy of treatments that have long been used and novel treatments with new ways to attack the calcinosis. So I just wanted to acknowledge that we have a Scleroderma Clinical Trials Consortium calcinosis working group that has been working very hard on developing new outcome measures, new patient-reported outcomes, and trying to better understand what causes calcinosis in scleroderma patients. So this is actually an international effort, including centers throughout the United States, Europe, Australia, and Canada. And we're all working together and hoping to find better treatments for calcinosis. And then finally, I just want to thank my colleagues at the Stanford Scleroderma Center, in particular David Fiorentino, who co-runs the Scleroderma Clinic with me, as well as my pulmonary and gastroenterology colleagues. And I'd like to thank the Scleroderma Foundation for inviting me to speak here today. Be happy to take any questions.
Can you hear me? I just had two terminology questions and one personal question.
Okay.
The terminology questions was, when I hear skin necrosis, does that mean gangrene?
Essentially, yes.
Okay.
It means gangrene of the layer of skin, yes.
Okay. And the second terminology question was, increases calcium solubility. What does that mean?
So it makes the calcium dissolve, basically.
Okay. All right. And my personal question was, I went to see a wound care doctor, and I think on 2 occasions, maybe it was, there was something that had broke through my elbow, and it was kind of white and maybe a little yellow. And then she took it and she broke it off. Is that calcinosis?
It could be. What did she do to it?
It was coming through the skin, and I guess surgically, she just broke it off.
Okay.
And then the skin healed and closed up.
Yeah. So sometimes you can actually extrude or get the calcium from under the skin, and that's what I was talking about. Some patients will actually try and do this themselves, and you can get like a little pebble that comes out, and it does relieve the tension and make you feel better actually getting it out. But
now, is it just what she took away? Is that just a teeny piece of something bigger?
the only way you would know is by doing some sort of imaging study, like an X-ray. You could see how much calcium is still there. If you can't actually see it under the skin or can't feel it, she may have actually gotten it all out, but you can use an X-ray to see if there's still some small pieces there. If you're
so should I be proactively pursuing to know how much calcinosis I have, or do you only address it when it breaks through?
You know, I think that at this stage, you probably don't need to know how much is there, because if it's not bothering you, then I wouldn't worry about it. But if it is, if you feel like there's still a nodule there that you keep traumatizing or that it's draining, then it's probably worthwhile to see how much is there, because it's possible that you could have it completely surgically removed.
Thank you so much for answering my question, and I appreciate your way of presenting. It was very calming at the end of a busy day.
You're welcome.
I have several questions, actually. I have calcinosis, and on my kneecaps, I have probably on my x-rays, they said about 1.5 inches worth on the top of my kneecap. when I presented surgery, because I had heard that that was an option, they seem like they're hesitant or not interested in maybe doing surgery with me. And the reason they said was that reoccurrence, and then also that it could come even more severe, which makes me hesitant on that because it's already so bad. Do you have any thoughts about that?
Yeah, so like I said, the recurrence rate is about 25%. So I think that the non-recurrence rate is 75%, so you can always look at it that way. You know, if they were concerned that there was some nerve damage or joint damage that might happen with the surgery, I think that's different. But with respect to the recurrence rate, I think that the potential for it to not recur is higher than not. And potentially, if you use medical therapies concurrently with the surgery, that you'll have better chances in it not recurring.
Okay. And then another question I had is, could it be internal? Could it because you talked about it developing in the soft tissues around like joints and stuff like that. Can it be internal, like around your organs?
Certainly in dermatomyositis patients that happens, and it can be, like I said, plate-like or plaque-like, and actually can, you know, surround organs, can compress on nerves. It's a little bit less common in scleroderma to be really internal, and more common to be on the extremities, but still can cause problems depending on the location and the size.
And then I have one more thing, and then I'll pass it along. They had found that I had a vitamin D deficiency, and so they started me on a vitamin D supplement. Well, I noticed when I started taking that supplement, my calcinosis, my lesions started opening up more. I felt like they were growing maybe a little bit. Have you heard any correlation between vitamin D and calcinosis?
That's a great question. I haven't, but I would be interested to know more. And we should, since now vitamin D supplementation is so frequently given, that'd be interesting to look at in our scleroderma patients with calcinosis.
I have a question, but I also want to make a comment. My son had calcinosis in the back of his legs, and he did have them removed surgically with success. So I just wanted to let you know that.
That's great.
And that was done by a plastic surgeon. So is that the type of doctor you would
Yes.
normally go to?
Yes, usually plastic surgery. We have a fantastic hand surgeon who does all of the scleroderma patients that it's typically affecting the upper extremities, but usually the plastic surgeons can do lesions anywhere on the body.
He does also have it on his back.
On
But
his
it's-
back?
Yeah, but it's not visually noticeable. So he did have an x-ray, and it doesn't look like it's on his spine. So,
Still on the soft tissue.
yeah.
So if it's bothering him, like when he's lying down, it's not uncomfortable, then I think probably worth surgically removing. But if it's really small and not bothersome, then, you know, you can just watch it. Hopefully it won't grow.
Well, I'm wondering, because he is complaining of his back bothering him, so now I'm wondering if it's from the calcinosis. So,
It may be worth getting evaluated for removal.
okay. And that would be to a plastic surgeon? Okay, thank you.
I've had shoulder surgery, and they went in and removed all the calcium. The question is, I've had other joints replaced because of the destruction. Could that have caused the calcium in the joints caused the destruction?
So the calcium in your joints, I think, is actually different from calcium under the skin. You may have had like calcified tendonitis or something, but I think that process is not necessarily the same thing as calcinosis that's depositing under the skin. You have that too. Yeah, I think that they're actually not related, but I can't say for sure. But we don't have, most of our patients who have calcinosis under the skin don't necessarily get calcification in their joints as well.
I've had, I think, 7 hand surgeries, and every
7?
time, 7, not for calcification, for joint fusions. And every time I have a hand surgery, I also have calcium deposits removed at the same time. And I just want to tell everyone who's considering that it's always been successful, and I've never had any return, and I've been having those surgeries since 1998. So it's always
That's
been
great.
successful. Yeah.
That's great. And no trouble with wound healing? Or,
No, not at all.
Yeah, that's what we find at our center as well.
First off, let me thank you for coming and presenting. I understand what your son's going through. Most of my calcinosis is in the hips, the back, the groin area. My doctor recently asked if I would be willing to go through it's bisphosphonate, but it's a IV infusion, once a year IV infusion. We're still seeing if it's going to work or not. I only did it a couple months ago. But,
I'm sorry, what was the drug that he's infusing?
oh, I forget what it's called, but it's a bisphosphonate.
A bisphosphonate, I see, yes, Zonita?
I don't remember, but
Okay.
it's a once a year IV
Yeah.
infusion for osteoporosis.
Okay, yeah, so like I said, probably for all of these medical therapies, it takes a long time to see a difference. So I imagine you'll probably have to get another infusion next year and see how it does.
Yeah, with how thick mine is, unfortunately, I think so. But I noticed that you said that it can be caused by trauma. Is there a specific trauma, or is that something that we don't know?
That's something we don't know. We just think that repetitive trauma plays a role.
Okay, thank you.
Thank you for coming. I am wondering if we should limit the amount of calcium we take orally.
That's a good question. I personally don't think so, because you are absorbing the calcium through the gut, and hopefully it's going into your bones where you want it to go. So as I mentioned, there's that term dystrophic calcification, which is what we use to define calcinosis affecting scleroderma and dermatomyositis. And really, patients have normal blood levels of calcium and phosphorus, so I think that taking in calcium to protect your bones is necessary, and it's not necessarily going to worsen your calcinosis.